I want to thank the organizers of this meeting for inviting me to speak, and congratulations. I bring greetings from Tanzania, where I am here seeing the first group of interventional radiologists, fellowship trained, graduate from Tanzania from Muhimbili Hospital. I'm here to talk about the role of interventional radiologists for massive GI bleeding. I have no relevant financial disclosures. So GI bleed, as we know, is very common. It is absolutely something that is deadly and is responsible for more than 500,000 hospital admissions to internal medicine departments, surgery departments every year. And it is quite costly, approximately $6,000 per admission, $5 billion in direct costs, and lots of in-hospital deaths. The diagnosis and treatment of acute GI bleed have changed over the years. However, the mortality rates have hovered somewhere around 8 to 10% over the last 50 years. Timely evaluation remains critical to proper management. Now, angiography is the mainstay for many patients with difficult clinical problems. My talk today will concentrate on acute massive GI bleeding and the role of interventional radiology. But before we get too far, let's look at a case together. This is a 56-year-old who came in, presented with massive GI bleed, is undergoing endoscopy after receiving many units of blood. A phone call to the interventional radiology lab. Hey, we have a patient here who is known to be alcoholic, who needs an emergent TIPS. Last imaging was done in 2015 that shows cirrhosis. The CT scan was not helpful. But for this patient, you can see that the lines and tubes are in place, and most importantly, the SB tamponade balloon is in place. Balloon tamponade is highly effective and controls acute bleeding in up to 90% of patients with variceal bleed, although 50% will rebleed when the balloon is deflated. An appropriately placed SB tube allows resuscitation, safe transportation to endoscopy, to IR, and even to surgery. Now, this patient had a CT scan that showed distended stomach with lots of layers of clots within the stomach and an area of active extravasation in the stomach. Since I'm talking to surgeons, I'll point out here that yes, there are gallstones, but there are no signs of cirrhosis, portal hypertension, or bleeding varices. An angiogram was done that shows active extravasation within the stomach. And yes, embolization was performed pre and post to stop the bleeding. An SMA run was done to look for backfilling of the area that was bleeding. So yeah, I am the elephant in the room. I'm the person that is going to be looking at imaging, because my role is to talk about interventional radiology and our role in managing massive GI bleeds. So the manifestation of GI bleed depends on its source, and differentiating if it's an upper or lower GI bleed, whether it's a variceal bleed or non-variceal bleed, both are very important as we continue to resuscitate this patient. And so the luxury of making the diagnosis and before doing something is not always afforded to us. And so we're always working together in a team approach with the surgeons, the GI experts, critical care specialists, the interventional radiologists, and skilled nursing in trying to figure out what is best and how to manage these patients. So the requested procedure for this patient was a TIPS, which is indicated for patients with cirrhosis and variceal bleed. 30 to 50% of patients with portal hypertension will bleed from varices, and about 20% of them will die after the first bleed. Uncontrolled variceal bleed, unresponsive to endoscopy, the medical management, the main indication for TIPS and contraindication for TIPS include patients with severe heart failure, patients for which the portal vein or the hepatic vein is thrombosed. And we actually have methods of doing TIPS even in those patient populations. So appropriate patient selection is crucial. TIPS itself has an increased mortality in patients who have Child's class C cirrhosis, or in patients where the MELD score is high. And the MELD score itself has been shown to outperform the Child-Pugh score in many recent studies, where we know that if the MELD score is greater than 19, it is associated with a 20% 6-week mortality. Bilirubin greater than 3 has a 40% increase in death for each 1 milligram per deciliter above 3. And so choosing which patients would benefit from TIPS, even in the setting of acute massive hemorrhage, is important. The use of intracardiac echo now has allowed the procedure to be safer and faster, and has allowed this procedure to be done outside of academic institutions. And TIPS with ICE can shorten procedure times up to 30%, as seen in our own institution. Variceal bleed does not always result in TIPS though, because 80 to 85% of cirrhotic patients have gastric varices and have a significant mortality rate with bleeding. Balloon occluded retrograde transvenous obliterans, BRTO, has been shown to be a life-saving procedure in patients with bleeding from isolated gastric varices, especially in patients that are poor candidate for TIPS due to heart failure or advanced liver disease. But back to our case. So our patient presented with massive GI bleed, first-line therapy failed, called to IR, the patient may need a TIPS, etc., but saved by Imogen, the patient's shown with the active extravasation within the stomach underwent successful left gastric artery embolization. So not all bleeding in patients with cirrhosis will be variceal, and not all people who drink will actually have cirrhosis. Now, acute non-variceal bleed remains a challenging issue, and despite the liberal use of endoscopy and many medical therapies addressing the most common causes of peptic ulcer disease, gastric ulcer, or duodenal ulcer, the mortality and morbidity remain significantly high. This year, the American College of Gastroenterology released their new guidelines for management of patients with upper GI bleed due to ulcers. And yes, endoscopy is the first line in achieving bleeding control. And when it does work, it is fantastic. But if it doesn't work, transarterial therapy is considered a safer alternative than surgery due to especially in high-risk patients. In many institutions, transarterial embolization is now the first-line intervention for massive arterial bleeding from upper GI tract, as in my institution. So upper GI bleeding, transarterial embolization is indicated for patients who need to have their bleeding managed because they're continually bleeding. But we understand that there are patients where the rate of bleeding is so rapid where surgery is preferable. So only to continue to underscore the need for multidisciplinary team as we try to decide what to happen with these patients, because angiography definitely can be done to isolate where the bleeding is coming from and treat, but it can only be done if the patient is bleeding at the exact time of angiography or stigmata of previous bleeding is seen. And bleeding as low as 0.5 cc's per minute can be seen angiographically. Radionuclear scan, as in tag red cell scan, is very sensitive to bleeding and not specific. CT angiogram has a detection rate of 0.3 cc's per minute, also very sensitive, but gives us a lot of specific information so that we are able to go to the exact site of bleeding. So I want to emphasize not to look over the CT angiogram, even in cases of massive GI bleed. So the angiographic therapy is going to depend on the location of the bleed, whether we can get our catheters there. And yes, we can go femoral and sometimes we can go radial, but communication with our surgical colleague is king. Now, this is an area in the body where IR tends to be king. So this is a case of a patient who underwent Whipple procedure, who had massive bleed from their drain, and imaging was done to show that the bleeding happening right at the anastomotic site in the region of the gastroduodenal artery. And yes, this is a place where we enjoy being in this space so that we are able to provide not just embolization, but stent grafting of the gastroduodenal artery. And in the space of the gastroduodenal artery, prophylactic embolization in the case of peptic culture disease can also be done, because this is a place where bleeding, seen active extravasation is not needed. We have several things in our toolkits and more to come, whether we're embolizing with coils that are fibred, coils that have hydrogel, particles. The choices are endless and are definitely used based on the specific situation. And now we have a new kid on the block, liquid embolics like glue or onyx, that now have been used and seem to have an advantage over coils and even microcoils, because the rebleeding rate after embolization with liquid embolics seem to be much lower and carry a certain advantage. Here are some that are available. We use Trufil in the United States, and there are trials going on right now to look at the advantages of liquid embolics, especially in lower GI bleeds. Lower GI bleeds account for 20% of all acute bleeds. And yes, we know that most stop spontaneously. We know that diverticular bleed is the most common. And this is also where angiography can be done. Now, in this particular patient, we can see that there is active bleeding in the region of the hepatic flexure by the right colic artery, and we can coil embolize very well. Now, does embolization work? We say yes. What is the definition of success? There's no standard definition, but we know that we see clinical success where we can stop the bleeding and even transform someone that is having massive bleeding to where they can have definitive surgery. In the American College of Gastroenterology, their guidelines for acute lower GI bleed suggest that transarterial therapy can be done in some patients, but because of the episodes and incidents of rebleeding, that we bow out to our surgical colleagues and to our gastroenterology colleagues in many cases. So in summary, managing massive GI bleed in the upper tract or the lower tract remains a challenge, and a multidisciplinary team of skilled endoscopists, intensive care specialists, experienced GI surgeons, and interventional radiologists all have a role to play. The safety and efficacy of transarterial therapy for the treatment of life-threatening acute variceal and non-variceal bleed is now widely accepted and considered the gold standard for endoscopy refractory patients. Now, the future for IR in the space of embolization of massive upper GI bleed, we know depends on robotic guidance, smarter embolic catheters and embolic materials, using machine and artificial intelligence to help us to predict our outcomes. We know that we need better radiation protection, as some of these cases tend to go quite a bit away, and that health equity in this space is very much needed. Thank you for your attention. Have a great rest of meeting.